Hello everyone, and welcome to another episode of Advanced Pharmacology. Today we're talking about Chapter 36, your drugs acting on the renin-angiotensin-aldosterone system. So, jumping right in this chapter we consider four families of drugs. The first, angiotensin-converting enzymes, the inhibitors, also known as ACE inhibitors. Second, your angiotensin II receptor blockers, also known as ARBs, direct renin inhibitors, or DRIs, and lastly, the aldosterone antagonists. With all four groups, effects resulting from the interfering with the renin-angiotensin-aldosterone system, or RAAS, the ACE inhibitors have been available since the 1980s and have established roles in the treatment of hypertension, heart failure, and diabetic nephropathy. In addition, these drugs are indicated for myocardial infarction and the prevention of the cardiovascular events in patients at risk. Indication for ARBs are limited to hypertension, heart failure, diabetic nephropathy, and the prevention of cardiovascular events in patients who are at risk. The aldosterone antagonist eplerenone has two indications: hypertension and heart failure. Aldactone, or spironolactone, is also used to prevent a diuretic-induced hypokalemia and treat hyperaldosteronism. The current indication for DRIs are limited to hypertension. We begin reviewing the physiology of the RAS, and then we will discuss the drugs that can affect it. So, the physiology of the RAS system. The RAS plays an important role in the regulating blood pressure, blood volume, and fluid and electrolyte balance. In addition, the system appears to mediate certain physiologic changes associated with hypertension, heart failure, and myocardial infarctions. The RAS exerts its effects through angiotensin II and aldosterone. Speaking on angiotensin, before considering the physiology of RAS, we need to introduce the angiotensin family, which consists of three different angiotensins, and they are angiotensin 1, 2, and 3. All three compounds are small polypeptides. Keep in mind, angiotensin 1 is the precursor of angiotensin 2 and has only a weak biologic activity. In contrast, angiotensin 2 has a strong biologic activity, whereas angiotensin 3, which is formed by the degradation of angiotensin 2, has a moderate biologic activity. So again, the first being weak, the second being the strongest, and the third being somewhere in the middle. All right, so here is a picture denoting that. So again, as always, if I ever go too quickly, please hit the pause button. Again, this is the physiology aspect of it. If you're unfamiliar, pause, review, get yourself familiarized. So, actions of angiotensin 2. Angiotensin 2 participates in all processes regulated by the RAS. The most prominent actions of the angiotensin 2 are vasoconstriction and the stimulation of aldosterone release. Both actions raise your blood pressure. In addition, angiotensin 2 can act on the heart and blood vessels to cause pathologic changes in their structure as well as their function. So, for instance, vasoconstriction. Angiotensin 2 is a powerful vasoconstrictor. The compound acts directly on the vascular smooth muscle to cause contraction. Vasoconstriction is prominent in your arterioles and less so in veins. As a result of angiotensin-induced vasoconstriction, your blood pressure rises. In addition to its direct action on blood vessels, angiotensin 2 can cause vasoconstriction indirectly by acting on the sympathetic neurons to promote norepinephrine release. the adrenal medulla to promote epinephrine release, and lastly, the central nervous system to increase sympathetic outflow to blood vessels. So, the release of aldosterone, angiotensin II, acts on the adrenal cortex, which promotes the synthesis and the secretion of aldosterone, whose actions are discussed a little later. The adrenal cortex is highly sensitive to angiotensin II, and hence, angiotensin II can stimulate aldosterone release even when angiotensin II levels are relatively low to induce vasoconstriction. Aldosterone secretion is enhanced when the sodium levels are low and when potassium levels are high. Here are alterations of cardiac and vascular structure. Angiotensin II may cause pathologic structural changes in the heart and blood vessels. In the heart, it may cause hypertrophy or remodeling. In hypertension, angiotensin II may be responsible for increasing the thickness of blood vessel walls. So, for instance, in atherosclerosis, it may be responsible for the thickening of the intimal surface of the blood vessels. And in heart failure and myocardial infarctions, it may be responsible for causing the cardiac hypertrophy and the fibrosis. Known effects of angiotensin II that could underlie these pathologic changes include the following. So, one being the increased migration, proliferation, and hypertrophy of VSM cells. Second, the increased production of the extracellular matrix by VSM cells. VSM being vascular smooth muscle. Third, hypertrophy of the cardiac myocytes. And lastly, the increased production of the extracellular matrix by cardiac fibroblasts. So, actions of aldosterone. The regulation of blood volume and blood pressure. After being released from the adrenal cortex, aldosterone acts on the distal tubules of the kidney to cause the retention of sodium and the excretion of potassium and hydrogen. Because the retention of sodium causes water to be retained as well, aldosterone increases blood volume, which therefore causes blood pressure to rise. The pathologic cardiovascular effect, therefore. Until recently, knowledge of aldosterone's actions were kind of limited to the effects of the kidney. Now, however, we understand that aldosterone can cause more harmful effects. Similar to angiotensin II, aldosterone can promote cardiac remodeling and fibrosis. In addition, aldosterone can activate the sympathetic nervous system and suppress uptake of norepinephrine in the heart, thereby predisposing the heart to dysrhythmias. Also, aldosterone can promote vascular fibrosis, and it can disrupt the baroreceptor reflex. These adverse effects appear to be limited to states such as heart failure, in which the levels of aldosterone can be extremely elevated. So here is a good spot to hit pause so you can see the patient-centered care across the lifespan on RAS inhibitors. And I'll leave that up for just a moment. So, speaking on the formation of angiotensin II by renin and the angiotensin-converting enzyme, or ACE. Angiotensin II is formed through two sequential reactions. The first is catalyzed by renin and the second by ACE. So we'll talk about renin first. Renin catalyzes the formation of angiotensin I from angiotensinogen. This reaction is the rate-limiting step in angiotensin II formation. Renin is produced by the juxtaglomerular cells of the kidney and undergoes a controlled release into the bloodstream, where it cleaves angiotensinogen into angiotensin I. So, the regulation of renin release. Because renin catalyzes the rate-limiting step in angiotensin II formation, and because renin must be released into the blood in order for it to act, the factors that regulate renin release regulate the rate of angiotensin II formation. So, the release of renin can be triggered by a couple different things. Release increases in response to a decline in blood pressure, blood volume, plasma sodium content, or renal perfusion pressure. So when there is a reduced renal perfusion pressure, is an especially important stimulus for renin release and can occur in response to stenosis of the renal arteries, reduced systemic blood pressure, and a reduced plasma volume. For the most part, these factors increase renin release through effects exerted locally in the kidneys. However, some of these factors may also promote renin release through the activation of the sympathetic nervous system. The release of renin is suppressed by factors opposite to those that cause release. That is, renin secretion is inhibited by the elevation of blood pressure, blood volume, and plasma sodium content. Therefore, as blood pressure, blood volume, and plasma sodium content increases in response to a renin release, further release of renin starts to become suppressed. In this regard, we can view release of renin as being regulated by a classical negative feedback loop. So now your ACE inhibitors, or your angiotensin-converting enzyme, the kinase 2. ACE catalyzes the conversion of angiotensin 1. It's inactive into the angiotensin 2, which is the highly active. ACE is located in the luminal surface of all blood vessels. The vasculature of the lungs is especially rich in the enzyme. Because ACE is abundant, conversion of angiotensin 1 into angiotensin 2 occurs almost instantaneously after angiotensin 1 has already been formed. ACE is a relatively nonspecific enzyme that can act on a variety of substrates in addition to angiotensin 1. So the nomenclature regarding ACE can be confusing and requires comment. As just noted, ACE can act on several substrates. When the substrate is angiotensin 1, we refer to the ACE or the enzyme as an ACE. However, when the enzyme is acting on other substrates, we refer to it by different names. Of importance to us, though, is when the substrate is a hormone known as bradykinin. We refer to the enzyme as kinase 2. So please remember, whether we call it ACE or kinase 2, we're talking all about the same enzyme. So, the regulation of blood pressure by the renin-angiotensin-aldosterone system. RAS is poised to help regulate blood pressure. Factors that lower blood pressure turn the RAS on. Factors that raise blood pressure will turn it off. However, although the RAS does indeed contribute to blood pressure control, its role is normovolemic. Sodium replete individuals is only modest. In contrast, the system can be a major factor in maintaining blood pressure in the presence of a hemorrhage, when you're dehydrated, or have sodium depletion. RAS, acting through angiotensin 2, raises your blood pressure through two basic processes: the vasoconstriction and the renal retention of water and sodium. Vasoconstriction raises blood pressure by increasing the total peripheral resistance. Retention of water and sodium raises blood pressure by increasing blood volume. Vasoconstriction occurs within minutes to a couple hours of activating the system and therefore can raise blood pressure rather quickly. In contrast, days, weeks, or even months are required for the kidneys to raise blood pressure by increasing blood volume. Angiotensin 2 acts in two ways to promote renal retention of water. The first being by constricting renal blood vessels. Angiotensin 2 reduces renal blood flow and thereby reduces glomerular filtration. Second, angiotensin 2 stimulates the release of aldosterone from the adrenal cortex. Aldosterone then acts on the renal tubules by promoting the retention of sodium and water and excretion of potassium. So, the local tissue, angiotensin 2, the production. In addition to the traditional RAS that we've been discussing, in which angiotensin 2 is produced in the blood and then carried to target tissues, angiotensin II is produced in individual tissues. This permits discrete, local effects of angiotensin II independent of the main system. Interference with local production of angiotensin II may underlie some effects of the ACE inhibitors. It's important to note that some angiotensin II is produced by pathways that do not involve ACE. So as a result, drugs that inhibit ACE cannot completely block angiotensin II production. So some of the prototype drugs that we're going to talk about are drugs that act on the RAS system. So your angiotensin-converting enzyme inhibitors, such as captopril, your angiotensin II receptor blockers, including losartan, your direct renin inhibitors, so aliskiren, and your aldosterone antagonist, eplerenone. So we'll start with the ACE inhibitors, angiotensin-converting enzyme inhibitors. The ACE inhibitor is an important drug for treating hypertension, heart failure, diabetic nephropathy, and myocardial infarctions. In addition, they are used to prevent adverse cardiovascular events in patients at risk. The most prominent adverse effects are cough, angioedema, first-dose hypotension, and hyperkalemia. For all of these agents, beneficial effects result largely from suppressing the formation of angiotensin II. Because the similarities among ACE inhibitors are much more striking than their differences, we will discuss these drugs as a group, rather than selecting a prototype to represent them. So, we'll start with the mechanism of action and overview of a pharmacologic effect. As shown in the figure 36.2, ACE inhibitors produce their beneficial effects and adverse effects by 1. Reducing levels of angiotensin II through the inhibition of ACE, and 2. Increasing levels of bradykinin through the inhibition of kinase 2. By reducing levels of angiotensin II, ACE inhibitors can dilate blood vessels, primarily your arterioles and to a lesser extent the veins. They can reduce blood volume through the effects on the kidney, and importantly, prevent or reverse pathologic changes in the heart and blood vessels mediated by angiotensin II and aldosterone. Inhibition of ACE can also cause hyperkalemia and fetal injury. Elevation of bradykinin causes vasodilation, secondary to the increased production of prostaglandins and that nitric oxide, and can also promote cough and angioedema. So here's that picture they were talking about. A good spot to hit pause if you're unfamiliar with the the physiology rather, not the pathophysiology. The pharmacokinetics. Regarding pharmacokinetics, the following generalization applies. And there's a couple. The first being nearly all ACE inhibitors are administered orally. The only exception is enalaprillate, which is an active form of enalapril, which is given via the IV route. Except for captopril and moraxopril, all oral ACE inhibitors can be administered with food. With the exception of captopril, all ACE inhibitors have a prolonged half-life and therefore can be administered just once or twice a day. Captopril is administered 2 to 3 times a day. With the exception of lisinopril, all ACE inhibitors are prodrugs, and that must undergo a conversion to their active form in the small intestine and liver. Lisinopril is already given in an active form, so it does not need to be metabolized. All ACE inhibitors are excreted by the kidneys. As a result, nearly all can accumulate to dangerous levels in patients who have kidney disease, and therefore dosage must be reduced in those patients. Only one agent, fosinopril, does not require a dosage reduction. So what are their therapeutic uses? When ACE inhibitors were first introduced, their only indication was to treat hypertension. However, today we also use it for heart failure, acute myocardial infarctions, and left ventricular dysfunction, as well as diabetic and non-diabetic nephropathy. In addition, they can help prevent myocardial infarctions, strokes, and death in patients at high risk for cardiovascular events. It should be noted that no single ACE inhibitor is approved for all of these conditions. However, given that all ACE inhibitors are very similar, it seems likely that all may produce a very similar benefit. So here is an outstanding spot to hit pause to look at all the different ACE inhibitors approved for indications at adult dosages. So the first being, for instance, hypertension. All ACE inhibitors are approved for hypertension. These drugs are especially effective against malignant hypertension and hypertension secondary to renal arterial stenosis. They are also useful against essential hypertension of mild to moderate intensity, although maximal benefit may take several weeks to develop. In patients with essential hypertension, the mechanism underlying blood pressure reduction is not fully understood. Initial response are proportional to the circulating angiotensin II levels and are clearly related to reduced formation of the compound. However, with a prolonged therapy, blood pressure often undergoes additional decline. During this phase, there is no relationship between reductions in blood pressure and the reduction in circulating angiotensin II. It may be that the delayed response is due to the reduction in local angiotensin II levels, reductions that would not be revealed by measuring angiotensin II in the blood. Your ACE inhibitors offer several advantages over most other antihypertensive drugs. In contrast to the sympatholytic agents, ACE inhibitors do not interfere with cardiovascular reflexes. Therefore, exercise capacity is not impaired, and orthostatic hypotension is usually minimal. In addition, these drugs can be used safely in patients with bronchial asthma, a condition that precludes the use of beta-2 adrenergic antagonists. ACE inhibitors do not promote hypokalemia, hyperuricemia, or hyperglycemia, so side effects seen with thiazide diuretics, for instance. Furthermore, they do not induce lethargy, weakness, or sexual dysfunction, responses that are common with any other kind of antihypertensive agent. Most importantly, ACE inhibitors reduce the risk for cardiovascular mortality caused by hypertension. The only other drugs provided or approved to reduce hypertension-associated mortality are beta blockers and diuretics, which we'll discuss more in Chapter 39. Their indication for heart failure. ACE inhibitors produce multiple benefits in heart failure. By lowering that arteriolar tone, the drugs improve regional blood flow, and by reducing cardiac afterload, they increase cardiac output. By causing venous dilation, they reduce pulmonary congestion and peripheral edema. By dilating blood vessels in the kidney, they increase renal blood flow and thereby promote excretion of sodium and water. This loss of fluid has two beneficial effects. It helps reduce edema, and by lowering blood volume, it decreases venous return to the heart and thereby reduces right heart workload. Lastly, by suppressing aldosterone and reducing local production of angiotensin II in the heart, ACE inhibitors may prevent or even reverse pathologic changes in cardiac structures. Although only 7 ACE inhibitors are approved for heart failure, both the American Heart Association and the American College for Cardiology have concluded that the ability to improve symptoms and prolong survival is a class effect. The use of ACE inhibitors in heart failure is discussed in more detail in Chapter 40. So, myocardial infarctions. ACE inhibitors can reduce the mortality after an acute myocardial infarction or heart attack. In addition, they decrease the chance of developing overt heart failure. Treatment should begin as soon as possible after infarction and should continue for at least 6 weeks. In patients who develop overt heart failure, treatment should continue long term. As for patients who do not develop heart failure, there are no data to indicate whether continued treatment would be beneficial. At this time, only 3 ACE inhibitors, captopril, lisinopril, and trandolapril, are approved for patients who've had a myocardial infarction. Diabetic and non-diabetic nephropathy. ACE inhibitors can benefit patients with diabetic nephropathy, the leading cause of end-stage renal disease in the United States. In patients with overt nephropathy are indicated by proteinuria of more than 500 milligrams per day. ACE inhibitors can slow this progression of renal disease. In patients with less advanced nephropathy, so someone who sits between 30 to 300 milligrams of proteinuria per day, ACE inhibitors can delay onset of overt nephropathy. These benefits were first demonstrated in patients with type 1 diabetes and were later demonstrated in patients with type 2 diabetes. More recently, ACE inhibitors have been shown to provide similar benefits in patients with nephropathy unrelated to diabetes. The principal protective mechanism appears to be the reduction of the glomerular filtration pressure. ACE inhibitors lower filtration pressure by reducing levels of angiotensin II, a compound that can raise filtration pressure by 2 mechanisms. The first, angiotensin II raises systemic blood pressure, which raises pressure in the afferent arteriole of the glomerulus. The second, it constricts the efferent arterioles by therefore generating back pressure in the glomerulus. The resultant increase in filtration pressure promotes injury. By reducing these levels of angiotensin II, ACE inhibitors lower glomerular filtration pressure and thereby slow the development of renal injury. So if you need a picture version of that information, you can hit pause here and take a look at it this way. At this time, the only ACE inhibitor approved for nephropathy is captopril. However, the American Diabetes Association is considering benefits in diabetic nephropathy to be a class effect and therefore recommends choosing an ACE inhibitor based on its cost and likelihood of patient adherence. So, can an ACE inhibitor be used for the primary prevention of diabetic nephropathy? The answer, unfortunately, is no. This conclusion is based on the Renin-Angiotensin system study, which evaluated that the effects of an ACE inhibitor, granted it was enalapril or Vasotac, and an ARB, losartan or Cozar, in patients with type 1 diabetes who did not have hypertension or any sign of early kidney disease. Both drugs failed to protect the kidney. Compared with patients receiving a placebo, those receiving enalapril or losartan developed the same degree of microalbuminuria, an early sign of kidney damage, the same decline in kidney function, and the same changes in the glomerular structure. Therefore, although an ACE inhibitor may slow the progression of established nephropathy, they do not protect against early kidney damage. The prevention of myocardial infarction, your stroke and death in patients at high cardiovascular risk. One ACE inhibitor, ramipril or Altase, is approved for the reducing of the risk of myocardial infarctions, strokes, and even death from a cardiovascular cause in patients who are at high risk for major cardiovascular events. High risk was defined as having either had a history of stroke, coronary artery disease, peripheral vascular disease, or diabetes, combined with at least one other factor such as hypertension, low-density lipoprotein cholesterol, low high-density lipoprotein cholesterol, or a history of cigarette smoking. Ramipril was approved for the use based on a result of the Heart Outcome Prevention Evaluation trial, also known as the HOPE trial, a large study in which patients at high cardiovascular risk took either ramipril or a placebo. Follow-up time was about 5 years later. The combined endpoint for an MI, stroke, or death from cardiovascular causes was significantly lower in the ramipril group, 14% versus the 18%, which was a 22% reduction in risk. Possible mechanisms underlying the benefit include the reduced vascular resistance and the protection of the heart, blood vessels, and kidney from the damage that angiotensin II and aldosterone could have caused over time. So, like ramipril, perindopril, or ASEAN can reduce morbidity and mortality in patients at risk for major cardiovascular events. Benefits were demonstrated in the European trial on the reduction of cardiovascular events with perindopril in stable coronary artery disease. Patients who were in this Europa trial were at a lower risk than those who were in the HOPE trial. Can ACE inhibitors and other than ramipril and perindopril also reduce cardiovascular risk? The question is a possibility. However, at this time, there's insufficient evidence that says so for sure. Diabetic retinopathy. The RAS trial showed that at least one ACE inhibitor, enalapril, can reduce the risk for diabetic retinopathy in some patients, specifically in patients with type 1 diabetes who do not have high blood pressure, nephropathy, or established retinopathy. Enalapril prevented or slowed the development of retinal changes. However, in patients with type 1 diabetes and an established retinopathy, enalapril had no more benefit. In patients with type 2 diabetes, enalapril had no benefit, regardless of retinopathy status prior to its use. So, what kind of adverse effects do ACE inhibitors have? ACE inhibitors are generally well tolerated. Some adverse effects, however, include hypotension and hyperkalemia, which are due to the reduction in angiotensin II, whereas others, such as cough and angioedema, are due to the elevation of bradykinin. So, first dose hypotension. A side effect. A precipitous drop in blood pressure may occur after that first dose of an ACE inhibitor. This reaction is caused because of a widespread vasodilation secondary to an abrupt lowering of angiotensin II levels. Your first dose hypertension is most likely in patients with severe hypertension, in patients taking diuretics, and in patients who are sodium depleted or volume depleted. To minimize the first dose effect, initial doses should be low. Also, diuretics should be temporarily discontinued, starting 2 to 3 days before starting an ACE inhibitor. Blood pressure should be monitored for several hours after the first dose of an ACE inhibitor. And if hypotension does develop, the patient should assume a supine position. If necessary, blood pressure can be raised with an infusion of normal saline. We also mentioned a cough. All ACE inhibitors can cause a persistent, dry, irritating, non-productive cough. Severity can range from a scratchy throat to severe hacking coughs. The underlying cause is the accumulation of bradykinin, secondary to the inhibition of kinase 2. Cough occurs in about 10% of patients and is the most common reason for discontinuing the therapy. Factors that increase the risk for cough include the advanced age, female sex, and Asian ancestry. Cough begins to subside 3 days after discontinuing the ACE inhibitor and is gone usually within the 10 days of discontinuation. Hyperkalemia. Hyperkalemia, the inhibition of aldosterone release, secondary to the inhibition of angiotensin II production, can cause potassium retention by the kidney. As a rule, significant potassium accumulation is limited to patients taking potassium supplements, use salt substitutes, which contain potassium, granted, or a potassium-sparing diuretic. For most other patients, hyperkalemia is generally rare. Patients should be instructed to avoid potassium supplements and potassium-containing salt substitutes unless they are specifically prescribed to the patient. Renal failure. ACE inhibitors can cause severe renal insufficiency in patients with bilateral renal artery stenosis or stenosis in the artery to a single remaining kidney. In patients with renal artery stenosis, the kidneys release large amounts of renin. The resulting high levels of angiotensin II serve to maintain glomerular filtration by two mechanisms: the elevation of blood pressure and the constriction of efferent glomerular arterioles. When ACE is inhibited, causing angiotensin levels to fall, the mechanism that has been supporting glomerular filtration will start to fail, causing urine production to drop precipitously. Not surprisingly, ACE inhibitors are contraindicated for a patient who has bilateral renal artery stenosis or stenosis in an artery with a single remaining kidney. So, there is a black box warning regarding ACE inhibitors, and that is due to its cause of fetal injury. The use of ACE inhibitors during the second or third trimester of pregnancy can injure the developing fetus. Specific effects include hypotension, hyperkalemia, and school hypoplasia, pulmonary hypoplasia, anuria, renal failure, granted reversible and irreversible, but more importantly, death. Women who become pregnant while using ACE inhibitors should discontinue treatment as soon as possible. Infants who have been exposed to an ACE inhibitor during the second or third trimester should be monitored more closely, again for that hypotension, oliguria, and hyperkalemia. So, are ACE inhibitors safe in early pregnancy in that first trimester? The answer is possibly, even though an article in the New England Journal of Medicine reported that among 209 children exposed to ACE inhibitors during the first trimester, 18 had major congenital malformations, compared with the 3.2% of controls. That data contrasts with animal studies, which suggested that such malformations are not likely. Furthermore, no mechanism by which ACE inhibitors might disrupt early embryogenesis is currently known. It is now thought that the malformations attributed to ACE inhibitors are more related to hypertension in pregnancy, not the drug itself. However, because there is a lack of complete data, the FDA still classifies ACE inhibitors in the pregnancy risk category D, and they should be avoided throughout the pregnancy. Bringing us to angioedema. Angioedema is a potentially fatal reaction that develops in about 1% of patients. Symptoms which result in the increased capillary permeability include giant valence and edema of the tongue, glottis, lips, eyes, and pharynx. Severe reactions should be treated with a subcutaneous epinephrine. If angioedema develops, ACE inhibitors should be discontinued and never be used again. Angioedema is caused by the accumulation of bradykinin, secondary to the inhibition of kinase 2. Neutropenia. Neutropenia, with its associated risk for infection, is a rare but serious complication. Neutropenia is most likely in patients with renal impairment and in those with collagen vascular disease. So think of your systemic lupus or scleroderma. These patients should be followed closely. Fortunately, neutropenia is reversible when detected early enough. If neutropenia starts to develop, ACE inhibitors should be withdrawn immediately. The neutrophil count should be normalized and back to normal in about 2 weeks. In the absence, however, of early detection, neutropenia may progress to a fatal agranulocytosis. Patients should be informed about early signs of infection, so your fevers, your sore throats, and be instructed to report them immediately. Neutropenia is more common when you use captopril than any other kind of ACE inhibitor. However, keep in mind any ACE inhibitor can cause neutropenia. Your drug interactions, your diuretics. Diuretics may intensify that first dose hypotension. To prevent this interaction, again, diuretics should be withdrawn 2 to 3 days prior to giving that first dose of an ACE inhibitor. Your diuretic therapy can then be resumed later on if needed. Your other antihypertensive agents. Again, hypotensive effects of ACE inhibitors are often additive with those of other antihypertensive drugs, whether it's your diuretics, your sympatholytics, your vasodilators, or calcium channel blockers. When an ACE inhibitor is added to your antihypertensive regimen, dosage of other drugs may require a reduction. Drugs that raise potassium levels. ACE inhibitors increase the risk for hyperkalemia caused by potassium supplements or a potassium-sparing diuretic. The risk for hyperkalemia is increased, again because we are suppressing aldosterone secretion. ACE inhibitors can reduce the excretion of potassium. To minimize the risk for hyperkalemia, your potassium supplements or your potassium-sparing diuretics should be employed only when clearly indicated. Lithium. ACE inhibitors can cause lithium to accumulate to a toxic level. Lithium levels need to be monitored frequently. Your nonsteroidal anti-inflammatory drugs, your NSAIDs, aspirin, ibuprofen, and other NSAIDs may reduce the antihypertensive effect of an ACE inhibitor. So how are they prepared? Your dosage and administration. Except for enalaprilat, all ACE inhibitors are administered orally. Of the oral products, all are available in a single drug formula. Most are also available in fixed-dose combinations with hydrochlorothiazide, a thiazide diuretic, and one agent. Pyrronitropril is available combined with indapamide. 2 ACE inhibitors, benazepril and trandolapril, are available combined with a calcium channel blocker. So, except for captopril and moxapril, all oral formulas may be administered without regard to meals. However, captopril and moxapril should be administered 1 hour before a meal. Dosages for all ACE inhibitors, except fosinopril, should be reduced in patients with a renal impairment. Dosage for specific indications are shown here in the next table. So, table 36.2 here is a good spot to hit pause so you can see all the ACE inhibitor combination drugs. Leading us to angiotensin II receptor blockers. Angiotensin II receptor blockers. Initially, ARBs were approved for only hypertension. Today, they are also approved for the treatment of heart failure, diabetic nephropathy, and myocardial infarction, and for the prevention of myocardial infarctions, strokes, and death in people at high risk for cardiovascular events. Like the ACE inhibitor, your ARBs decrease the influence of angiotensin II. However, the mechanisms involved differ. Whereas ACE inhibitors block the production of angiotensin II, ARBs block the action of angiotensin II. Technically, because both groups interfere with angiotensin II, they both have similar effects. They differ primarily that the ARBs pose a much lower risk, for instance, for coughs or for causing hyperkalemia. Even though ACE inhibitors and ARBs have very similar effects, these drugs are not clinically interchangeable. We have clear and extensive evidence that ACE inhibitors decrease cardiovascular morbidity and mortality. The evidence for ARBs is less convincing. Accordingly, until more is known, ACE inhibitors are preferred. For patients who cannot tolerate an ACE inhibitor, however, ARBs are an appropriate second choice. There's 8 ARBs that are available, and all 8 are very similar. Therefore, we'll discuss them as a group, rather than choosing one as a prototype. So, their mechanism of action. An overview of pharmacologic effects. ARBs block access of angiotensin II to its receptors in blood vessels, the adrenals, and all other tissues. As a result, ARBs have effects much like those of an ACE inhibitor. By blocking angiotensin II receptors on blood vessels, ARBs cause dilation of arterioles and veins. By blocking angiotensin II receptors in the heart, ARBs can prevent angiotensin II from inducing pathologic changes in the cardiac structure. By blocking angiotensin II receptors in the adrenals, ARBs decrease release of aldosterone and can thereby increase renal excretion of sodium and water. Sodium and water excretion is further increased through the dilation of renal blood vessels. In contrast to an ACE inhibitor, ARBs do not inhibit kinase 2 and therefore do not increase levels of bradykinin in the lungs. As a result, ARBs have a lower risk for causing a cough, the most common reason for stopping ACE inhibitors. So what are the therapeutic uses then of ARBs? All ARBs are approved for hypertension. The reduction in blood pressure equal those seen when using an ACE inhibitor. Evidence that ARBs share the ability of an ACE inhibitor to reduce mortality, however, is lacking. Heart failure. Currently, only 2 ARBs, valsartan and candesartan, are approved for heart failure. In clinical trials, these drugs reduced symptoms, decreased hospitalizations, improved functional capacity, and increased left ventricular ejection fraction. More important, they prolonged survival. Because experience with these drugs is limited, they should be reserved for patients who cannot tolerate ACE inhibitors. Although other ARBs are not yet approved for heart failure, most authorities believe they are effective. Diabetic nephropathy. 2 ARBs, irbesartan and losartan, are approved for managing nephropathy in hypertensive patients with a type 2 diabetes. In clinical trials, these drugs delayed the development of overt nephropathy and slowed the progression of established nephropathy. Benefits are due in part to reduction in blood pressure and in part to mechanisms that have not been determined. So how do ARBs compare with ACE inhibitors? Although both groups of drugs can delay progression of nephropathy, only the ACE inhibitors have been shown to reduce mortality. As noted earlier, neither ARBs nor ACE inhibitors are effective for primary prevention of diabetic nephropathy. Myocardial infarction. 1 ARB, valsartan, is approved for reducing cardiovascular mortality in post-MI patients with heart failure or left ventricular dysfunction. Approval was based on the result of a major trial, the valsartan and acute myocardial infarction trial. that showed that valsartan was as effective as captopril at reducing short-term and long-term mortality in patients. Stroke prevention. One ARB, losartan, is approved for the reduction in the risk for stroke in patients who have hypertension and left ventricular hypertrophy. In a clinical study, stroke prevention with losartan was better than with atenolol, a beta blocker, even though both drugs produced an equivalent decrease in blood pressure. This observation indicates that the benefit of losartan cannot be explained on the basis of the reduced blood pressure alone. The prevention of MIs, strokes, and death in patients at a high cardiovascular risk. One ARB, telmisartan, is approved for reducing the risk for MI, stroke, and death from cardiovascular causes in patients who are 55 years and older, but only if they are intolerant of ACE inhibitors. Approval of telmisartan was based on the on-target or ongoing telmisartan alone and in combination with ramipril global endpoint trial study, which showed that telmisartan was similar to ramipril with regard to reducing cardiovascular morbidity and mortality. Of note, combining telmisartan with ramipril was no more effective than either agent alone, but did increase the risk for adverse events. Can other ARBs reduce cardiovascular risk? Possibly, but again, the proof and evidence behind it is currently lacking. Your diabetic retinopathy. In the RAS study mentioned previously, benefits of an ARB losartan were like those of enalapril in patients with type 1 diabetes. Without established retinopathy, losartan showed that the development and the progression of retinopathy was slowed down, but had no benefit in a patient with established retinopathy. In patients with type 2 diabetes, the drug offered no benefit at all, regardless of retinopathy status. Its adverse effects. All ARBs are well tolerated. In contrast to the ACE inhibitors, ARBs do not cause clinically significant hyperkalemia. Furthermore, because ARBs do not promote accumulation of bradykinin in the lungs, they also have a lower incidence of causing a cough. However, the angioedema, like the ACE inhibitor, ARBs can cause angioedema, although the incidence may be lower with an ARB. If angioedema occurs, ARBs should be withdrawn immediately and again never be used. Severe reactions are treated with subcutaneous epinephrine. ARBs cause angioedema possibly by increasing bradykinin availability. Unlike ACE inhibitors, ARBs do not inhibit bradykinin breakdown. However, through an indirect mechanism, ARBs may be able to increase local bradykinin synthesis. About 8% of patients who experience angioedema with an ACE inhibitor will also develop that angioedema when given an ARB. Nonetheless, switching to an ARB may be worth the risk for specific patients, namely those with a disorder for which an ARB are known to improve their outcome, such as your heart failure, diabetes, and MI. So, ARBs do come with a black box warning to fetal harm. Similar to ACE inhibitors, ARBs can injure the developing fetus if given during the second and third trimester of pregnancy, and therefore are contraindicated during this period. Also, there's the concern that ARBs and ACE inhibitors may harm the fetus in early pregnancy, and therefore should be discontinued as soon as pregnancy is discovered. Renal failure. Like an ACE inhibitor, ARBs can cause renal failure in patients with bilateral renal artery stenosis or stenosis in the artery of a single remaining kidney. So, ARBs must be used with extreme caution in patients with either of those conditions, whether they have one kidney or both. Drug interactions. The hypotensive effects of ARBs are addictive with those of other antihypertensive drugs. When an ARB is added to an antihypertensive regimen, Dosages of other drugs may require a reduction. The preparation, dosage, and administration, therefore. All ARBs are administered orally, and all may be taken with or without food. All are available alone, and all but azilsartan are also available as a fixed-dose combination with hydrochlorothiazide, which is a thiazide diuretic. Dosages for each specific medication are shown in the following tables. So the first table here shows all the combo drugs, and the second, the indications. So it's an excellent spot to hit pause so you can take a look at it all. Which brings us to aliskiren, a direct renin inhibitor. DRIs are drugs that act on renin to inhibit the conversion of angiotensinogen into angiotensin 1. By decreasing the production of angiotensin 1, DRIs can suppress the entire RAS system. Currently, there is only one DRI, aliskiren, also known as Tecturna, which is available. Blood pressure reduction with aliskiren equals that seen with an ACE inhibitor. Aliskiren causes less cough and angioedema than an ACE inhibitor. However, it poses similar risks to the developing fetus. So how does it work? Aliskiren binds tightly with renin and thereby inhibits the cleavage of angiotensinogen, which forms into angiotensin 1. Because this reaction is the first and the rate-limiting step in the production of angiotensin 2 and aldosterone, aliskiren can reduce the influence of the entire RAS system. In clinical trials, the drug decreased plasma renin activity by 50 to 80%. Although aliskiren works at an earlier step than either the ACE inhibitor or the ARB, there's no proof that doing so results in a superior clinical outcome. Its therapeutic use, therefore. Aliskiren is approved only for the treatment of hypertension. It may be used alone or in a combination with other antihypertensives. In clinical trials, the medication reduced blood pressure to the same extent as did ACE inhibitors, ARBs, or a calcium channel blocker. Its maximal effects developed within 2 weeks, although aliskiren can reduce blood pressure in hypertensive patients. Data are conflicting regarding the reduction of negative outcomes, which include blindness, stroke, kidney disease, and death. The AVOID, which stands for aliskiren in the evaluation of proteinuria and diabetes, study demonstrates a renoprotective effect in diabetic patients when combined with losartan. Yet in the ALTITUDE, or aliskiren trial in type 2 diabetes using cardiorenal disease endpoints, trial, incidence of non-fatal stroke, renal dysfunction, and hypotension led to a premature closure of the study. Given these mixed results, more studies are currently underway. Until the long-term benefits and safety of aliskiren are known, older antihypertensives should be considered first. Its pharmacokinetics. Aliskiren is administered orally, and bioavailability is low, only 2.5%. Dosing with a high-fat meal makes availability even lower, about 0.8%. Aliskiren undergoes some metabolism via the CYP3A4 isoenzyme of the cytochrome P450, but the extent of the metabolism is yet unknown. About 25% of the drug is eliminated unchanged in urine, and its half-life right now stands at about 24 hours. It does come with adverse effects. Aliskiren is generally well tolerated. At usual doses, the risk for angioedema, cough, and hyperkalemia are low. At high therapeutic doses, however, some patients experience diarrhea. Like other drugs that affect the RAS system, aliskiren should be avoided during pregnancy. So, speaking on angioedema and cough. With ACE inhibitors, angioedema and cough result from the inhibition of kinase 2. Because aliskiren does not inhibit kinase 2, the risk for these effects are low. In clinical trials, the incidence of a cough was 1.1% with aliskiren versus the 10% with an ACE inhibitor. Similar, the incidence of angioedema was 0.06% with aliskiren versus the 1% with an ACE inhibitor. If angioedema does occur, aliskiren should be discontinued immediately. So it does mention gastrointestinal effects. Aliskiren causes dose-dependent diarrhea that was seen in 2.3% of patients taking 300 milligrams per day. Women and older adults are most susceptible. Excessive doses, so patients who are taking 600 milligrams or above, are associated with abdominal pain and dyspepsia. Hyperkalemia. Like the ACE inhibitor, aliskiren rarely causes hyperkalemia when used alone. However, hyperkalemia might be expected if aliskiren is combined with an ACE inhibitor, a potassium-sparing diuretic, or potassium supplements. Its black box warning, therefore, does state that aliskiren is known to be causing, fetal injury or even death. Although aliskiren has not been studied in a pregnant woman, the drug is likely to pose a risk for major congenital malformations and fetal death because the risk for these events is well established with other drugs that suppress the RAS system. Therefore, like the ACE inhibitors and ARBs, aliskiren is contraindicated during the second and third trimester and should be discontinued as soon as possible when pregnancy begins. Its drug interactions, therefore. Aliskiren undergoes some metabolism by CYP3A4, but it neither induces nor inhibits the P450 system. In clinical trials, aliskiren had no significant interactions with atenolol, digoxin, amlodipine, or hydrochlorothiazide. However, levels of aliskiren were significantly raised when using atorvastatin and ketoconazole, which is a P450 inhibitor, and significantly lowered by irbesartan. Levels of Lasix were also lowered by aliskiren. So what is its preparation, dose, and administration? Aliskiren is available alone as Tecturna and Raziles, in combination with hydrochlorothiazide as Tecturna HCT and Raziles HCT, and in combination with amlodipine as Tec-Amlo. All formulations are indicated for hypertension. Aliskiren alone is available in a 150 and 300 milligram tablet, and the initial dose should be 150 to start, once a day. If control of blood pressure is inadequate, dosage may be increased to 300 milligrams once a day. Daily doses above 300 milligrams will not increase the benefit, but will increase the risk for diarrhea. Because high-fat meals decrease absorption substantially, each daily dose should be taken at the same time with respect to meals, about 1 hour before dinner, to achieve a consistent response. Aliskiren hydrochlorothiazide tablets are available in 4 strengths: 150 milligrams and 12.5, 150 and 25, 312.5, and 325 for once daily dosing. As with Tecturna, each daily dose should be taken at the same time with respect to meals. Aliskiren amlodipine, Tec-Amlo tablets are available in 4 strengths as well: 150 milligrams and 5, 150 and 10, 305, and 310. For once daily dosing, as with any other medication prior, each dose daily should be taken at the same time with respect to meals. Which brings us to the aldosterone antagonists. Aldosterone antagonists are drugs that block receptors for aldosterone. Two such agents are available, eplerenone and spironolactone. Both drugs have similar structures and actions, and both are used for the same disorder, hypertension and heart failure. They do differ, however, in that spironolactone is less selective than eplerenone. As a result, spironolactone causes more side effects. Eplerenone, or Inspira, is the first-in-class selective aldosterone receptor blocker. The drug is used for hypertension and heart failure and has one significant side effect, hyperkalemia. So how does it work? Eplerenone produces selective blockade of aldosterone receptors, having little or no effect on receptors for other steroid hormones, such as your glucocorticoids, your progesterone, or androgens. In the kidney, activation of aldosterone receptors promotes the excretion of potassium and the retention of sodium and water. Receptor blockade has the opposite effect, retention of potassium and increased excretion of sodium and water. The loss of sodium and water reduces blood volume and hence blood pressure. Blockade of aldosterone receptors at non-renal sites may prevent or even reverse pathologic effects of aldosterone on cardiovascular structure and function. Its therapeutic use for hypertension is the treatment of hypertension. Eplerenone may be used alone or in combination with any other antihypertensive agent. Maximal reduction in blood pressure take about 4 weeks to develop. In clinical trials, reduction of blood pressure were equivalent to those produced by aldactone and superior to those produced by losartan. In patients already using an ACE inhibitor or an ARB, adding eplerenone produced a further reduction in blood pressure. Although it is clear that eplerenone can lower blood pressure, we have no information on what really matters: the drug's ability to reduce morbidity and mortality in patients with isolated hypertension and a lack of left ventricular hypertrophy. Until more is known, eplerenone should be reserved for a patient who has not responded to traditional antihypertensive medications. So heart failure. In patients with heart failure, eplerenone can improve symptoms, reduce hospitalizations, and prolong life. Benefits appear to derive from blocking the adverse effects of aldosterone on cardiovascular structures and function. The use of eplerenone in heart failure is going to get discussed in more detail in Chapter 40. So it's pharmacokinetics. Eplerenone is administered orally and absorption is not affected by food. Your plasma levels peak at about 1.5 hours after dosing. Absolute bioavailability is, however, unknown. Eplerenone undergoes metabolism via CYP3A4, followed by the excretion in the urine of 67% and feces of 32%. The elimination half-life is 4 to 6 hours. Bringing us to adverse effects. Eplerenone is generally well tolerated. The incidence of adverse effects is nearly identical to that of a placebo. A few adverse effects, however, include diarrhea, abdominal pain, cough, fatigue, gynecomastia, flu-like symptoms, which occur slightly in 1 to 2% more often with eplerenone than with the placebo. Hyperkalemia. The greatest concern is hyperkalemia, which can occur secondary to potassium retention. Because of this risk, combined with potassium supplements, salt substitutes, or potassium-sparing diuretics, is considered contraindicated. Combined with the use of ACE inhibitors or ARBs is permissible but should be done with caution. Eplerenone is contraindicated for patients with a serum potassium above 5.5 and for patients with impaired renal function or type 2 diabetes with microalbuminuria, both of which can promote hyperkalemia. Monitoring potassium levels is recommended for patients who are taking ACE inhibitors and ARBs as well. So, drug interactions. Inhibitors of CYP3A4 may increase the levels of eplerenone, thereby posing a risk for toxicity. Weak inhibitors such as erythromycin, saquinafir, verapamil, and fluconazole can double eplerenone's levels. Strong inhibitors, urketoconazole and itraconazole, can increase the level almost fivefold. If eplerenone is combined with a weak inhibitor, the dosage for eplerenone should be reduced. Eplerenone should not be combined with a strong inhibitor. Drugs that raise potassium levels can increase the risk for hyperkalemia, so eplerenone should not be combined with potassium supplements, salt substitutes, or potassium-sparing. I'm sorry, I accidentally lost my spot. Should not be combined with potassium-sparing diuretics. Combination eplerenone with ACE inhibitors or ARBs should be done also with severe caution. Drug similarities to eplerenone. So your ACE inhibitors and diuretics are known to increase levels of lithium. Although the combination of eplerenone and lithium have not been studied, caution is nonetheless advised. Lithium levels should be measured frequently. So how is it prepared? Its dosage and administration. Your eplerenone or Inspira is available in 25 and 50 milligram tablets. The usual starting dose is 50 milligrams once a day, taken with or without food. After 4 weeks, dosage may be increased to 50 milligrams twice daily if hypotension response has been inadequate. Raising the dosage above 100 milligrams is not recommended because doing so is unlikely to increase the therapeutic response, but will increase the risk for hyperkalemia. So, in patients taking weak inhibitors of a CYP3A4, the initial dosage should be reduced by 50%. Bringing us to aldactone. Aldactone, or spironolactone, a much older drug than eplerenone, blocks receptors for aldosterone, but also binds with receptors for other steroid hormones, your glucocorticoids, progesterone, and androgens. Blockade of the aldosterone receptor underlies beneficial effects in hypertension and heart failure, as well as the drug's major adverse effect, hyperkalemia. Binding with receptors for other steroid hormones underlies additional adverse effects. Gynecomastia, menstrual irregularities, impotence, hirsutism, and the deepening of the voice. The basic pharmacology of aldactone and its use in heart failure will be discussed in further detail in both Chapter 39 and 40, respectively. Aldactone does come with a black box warning. The use of spirolactone is tumorigenic in chronic toxicity studies in rats. That concludes our chapter here today. I thank you as always for listening, and I'll see you at chapter 37. Till then, thank you for listening, and have a wonderful day.